thank you all for coming. And obviously here, the most important person is Mr. Rex. I like to call him T-Rex. And I'm always horrible with last names. So
Griswold.
I'm not gonna even try.
Yeah.
Okay?
It's like the vacation movies.
There we go. Anyway, the point of this session is really for you guys to get exposure to a patient and be able to recognize these folks, and also what to ask these folks when you see them, keeping in mind that at the very beginning they are basically undiagnosable. You may suspect the diagnosis, you may think about it, you may put that in your differential, but by definition, unless the patient is advanced, it's impossible to diagnose MSA. So I would like for him to tell you his story from the beginning. You know, now obviously with 20/20 hindsight, things that 3 years ago were thought to be incidental or just part of getting over the hill. Of course, being over the hill myself, I don't think that would have been normal anyway, but that's another story. And just to get the sense of at least his progression, which is typical in many ways and atypical in others, and we'll go over the single aspect afterward. And please feel free to interrupt me. Don't interrupt him, please. And we'll see how that goes.
Okay, great.
So we'll start with, you're now 52.
52 now, yes.
And started to present to his physician at age 49,
Yes.
right? When you start to have something that said, this is just not right for someone that's active, healthy, and what the heck is going on with me?
Right. So within about 6-month time frame of around when I was 49, so basically 3 years ago, I had started with overactive bladder and urgency and constipation and ED. All three things happened within about 6 months of that time frame. And so I thought it was just part of turn 50. You just, those things just happen. And I go for an annual visit at Cooper Clinic in Dallas for a physical. And so the doctor there just decided to treat each of those three things individually. And I certainly didn't think they were connected at the time. So that went on for about a year, those three symptoms. And then September of 11, so that a little over a year ago, I started getting, almost 2 years ago, started getting ataxia symptoms. So I noticed that I couldn't carry an open coffee container any longer without spilling it. And I didn't really realize it, but I started slurring my words a little bit. The thing I did notice was my handwriting got to be horrible. I couldn't even read my own handwriting, basically. But I didn't put it all together. I used to be up until that point, I was still very active. Physically, I did triathlons, and I noticed that about November that I couldn't ride my bike very well anymore. I couldn't stand up on it and ride, and when you ride on the bike in traffic, it's scary enough on its own, but throw a taxi in on top of that, it gets worse. So I think February is when I was going to back to the doctor, and so to Cooper Clinic, to the physical. And so I decided that the night before I go, I'd write down everything that was wrong with me, because it became a laundry list, and I'd never had anything wrong with me. Always very healthy. And so all that was written down. I took it in. The doctor first thought maybe I had a stroke, and told me I needed to do several things as soon as I left. One thing was a MRI, several things, and see a neurologist. So I think in March of 12, I saw a neurologist for the first time, and it was a pretty big practice, and they had doctors that specialized in different neurology, but I just got into the first one, and he said he needed to send me on to someone who specializes in his practice in movement disorders, but he thought that I had ataxia. That's the first time I had heard of ataxia. And but he said before you see her, have an MRI, and there were several different tests that I had, and the radiologist report said I was normal on the MRI, but when the movement disorder doctor got it, she said that I actually had atrophy of the cerebellum. So she said I need to see a specialist. I lived at the time in Connecticut, and she said I need to go to a New York doctor that specialized in movement disorders because I definitely had ataxia. And she said, but before you go to that doctor, you need to have several tests run, and one of them was the Athena testing for SCA and the different types of hereditary ataxia. And of course, I was doing my own research at the time on ataxia, trying to figure out what that was, and I ran across a great site called ataxia.org, which I think is the official site for ataxia. And it was gave you a bunch of fact sheets of basically self-diagnosis. And when I got the Athena test results back, that it was not hereditary, it was sporadic. Then they basically said, read one of these fact sheets. So I read a fact sheet on MSA, and it was basically the first time that I put together the autonomic problems that I had were part of the cerebellar problems. And the fact sheet read like a biography.
So you actually made your own diagnosis?
Yes, I must state it all.
This was 4 neurologists later?
Yes.
Okay. So that says a lot about everyone, so don't feel bad if you miss one of these cases. Okay, that's the bottom line. Now, a couple of things. So let's start at the very beginning. So we have a 49-year-old guy, healthy, active. Well, age doesn't really explain developing ED, bladder problem, and constipation. Now granted, constipation is probably one of the most common symptoms, and frankly, if I look at my colleagues in GI, one of the most common diagnoses that we make these days is pelvic floor dysfunction, pelvic floor dyssynergia, these kind of things. So constipation that are functional, not structural. But whenever you have someone that is not diabetic, is not a peripheral vascular disorder disaster, and presents with ED, bladder, bowel symptoms, really the bells should go off in your head. 6 months, it's a fairly short timeline. At the same time, it's a relatively too long if we think, for instance, of an autonomic ganglionopathy. But that could still have been something that should have been considered, or basically cholinergic neuropathy. Now, ED obviously is generally the first sign. Why? Because to have normal sexual function, the system has to be perfectly in sync and work perfectly well. Otherwise, things start falling apart. That's why it's usually the first thing. While other systems are less susceptible to really such a perfect balance, or at least they have a little bit more margin. ED is definitely generally the first thing, particularly in males, obviously. Females is very harder to catch that. Things that were notably missing in his case, that you say, okay, let's say I'm thinking of an autonomic ganglionopathy. Well, he had no symptoms of dry eyes or dry mouth, no sicca, in other words. And he had no upper GI symptoms, which are usually fairly classic for the autonomic ganglionopathy. So symptom of bloating, nausea, early satiety, symptom of gastroparesis, essentially, okay? Well, lower GI is definitely the trademark for these more chronic neurodegenerative forms. He still, 3 years into this, does not appear to have symptom of sicca, and does not have a problem with sweating, which is another thing that normally we see in these folks. Again, every patient can start with a different set of symptoms. Or they may have had symptoms that started before and they may have not recognized, or again, attributed it to something else. And only after they present with symptom number 2, 3, 4, you put everything together. Not everyone develops necessarily everything, but it's good for you to go through the list and ask them about all the other possible present things, because the patient may not volunteer them simply because they may be embarrassed, or they may not know they are pertinent, or they may not have noticed it, because I have sometimes patients that think about it and say, funny you asked. Gee, I think that's what's been happening, okay? So, again, as I usually say, shake the tree and see which apples fall in your lap. And don't be in a hurry to make this diagnosis. This is, from our autonomic standpoint, is the equivalent of what ALS is in the neuromuscular group. You cannot make the diagnosis now, although you may suspect it. Just see the patient back in 6 months, repeat the test, see what's happening, and usually by 6 months, 12 months, the diagnosis becomes more apparent. Other things that I already know he does not have, because I spoke with him with the prior group, which is a bit unusual for these forms. He does not have any sleep disturbance in terms of, well, he has insomnia, but that's a separate issue. He does not have REM behavior disorder, which is probably indeed a little bit more common in the Parkinsonian variant than the cerebellar variant of multiple system atrophy, but usually is present and may actually precede everything else by decades. We now know that if you have REM behavior disorder, if you live long enough, you will develop some neurodegenerative disorder of some sort, okay? That's now, it's pretty much proven. But he has none of these, and also, quite importantly, he has none of the various sleep disorder, breathing abnormalities that we may have with multiple system atrophy. That's something you definitely need to ask about. The patient may not know, but they're bad partner. And if they don't have a bad partner anyway, I think it's a good thing to get at least an overnight oximetry and then a formal polysomnogram. Why? REM behavior disorder is very unpleasant for whoever sleeps with them more than for the patient, and can be very unpleasant for the furniture around them. Obviously, they may injure themselves, so I had patients in extreme cases in which they have to sleep on the floor, just a mattress, empty room by themselves. But the other thing is really the breathing. Patients with multiple system atrophy develop central hypoventilation. They may have a variety of other abnormalities which are less severe. But when they start having stridor, it's time to have a tracheostomy, okay? Which can be definitely corrected during the day so they can speak. But it's something that needs to be recognized, because otherwise the patient may die in their sleep, okay? In terms of other manifestation, obviously he has the ataxia. You can obviously hear his speech is a classic ataxic speech. And he ambulates with a cane still pretty well. he can tell you about the handwriting. I was commenting before, now a lot of folks don't handwrite much anymore. I mean, we all have electronic gadgets, and some abnormalities become apparent only if you write long enough. Very few of us now write a letter. We send an email. So some things we're losing now with all this technology. On the other hand, it makes it a lot easier for the patient to communicate. So if before making your handwriting illegible was a big deal, this day and age is not. Even if you are a clumsy typist like I am, 2 fingers, you can type. But if they are quick typists, they may notice, obviously, that they're slow or very imprecise because of the clumsiness.
I used to be easy little classic typist, and I was very fast.
And now you slow down a bit.
Now I'm down to these 2 fingers, and I still miss. So
that's still.
So every single email has got red all over it. So I have to
Thank you
fix
for autocorrect. Yes. Other things you need to inquire when you hear the speech problem is if they have difficulty swallowing, because obviously the mechanism at the bulbar level are the same. Regarding the management, the other thing he does not have is orthostatic hypotension. He has no symptoms of orthostatic lightheadedness. And although he had some tests showing that his blood pressure is a little bit labile. So do we need to manage that? No, we just need to be careful when we treat other symptoms, not to worsen the blood pressure problem and everything else with medication side effects. And that's one of the main challenges of these patients. They have multiple domains of involvement. And one thing may be prominent at one point, the other one may add later. For some folks, some things may never happen, and not that all of them will develop necessarily everything, although probably if they live long enough, they will develop all those symptoms, including becoming a mixed type. So starting cerebellar and then develop also some Parkinsonian features and vice versa. But some folks remain fairly pure, if you want to put it that way. You just need to chase them because they're moving targets and they're always ahead of you. The management is, as I mentioned, focus on prioritize whatever is the most critical aspect. Normally, orthostatic hypotension is a big deal. Again, in his case, is not. And you already heard from Dr. Chelinsky what option do we have for the management. But regarding in his case, the bladder and the bowel were the original symptoms. Now, for bladder, bladder does only 3 things. I mean, 2 things basically: store, or which problem do you have, storage or the empty component. Most of the time, patients with MSA will develop a mixed pattern. They will have motor and autonomic abnormalities. What do I mean with that? They will have the detrusor sphincter dyssynergia. So the 2 will not communicate very well. So it's sort of the ataxia at that level, if you want to put it that way, plus the autonomic insufficiency. So they generally, although they may present with one thing, if you do a urodynamic study, they may have a mixed pattern with more than one abnormality, which translate into they become tricky to really manage them. So for instance, in his case, seemingly urgency is the biggest thing and still is to this day. So medications such as an anticholinergic will work quite well. 2 minutes. The problem is if they start to develop also difficulty emptying, then they may develop a mixture of urgency and retention. So you need to be very aware of that. That's why we need a urodynamic before giving these folks medication, because you may precipitate the situation. For the dyssynergia, unfortunately, there is nothing magic. Pelvic floor retraining doesn't work. It's really a neural control problem. So basically, you try to do the best you can, control the key symptoms, making sure you don't create a disaster, worsening other aspects. Give them a regimen, and then as they evolve, most of these folks end up with self-catheterization. for obvious reason. Regarding the bowel, again, anticholinergic medication for urgency can precipitate the constipation situation. Things like Miralax and promotility agent usually work fairly well. Stay ahead of the bowel, otherwise you then allow the gut to have bacterial overgrowth and then they have explosive diarrhea. So that's not a good situation because they may develop urgency with the bowel too. Erectile dysfunction is difficult. You can certainly start with a traditional drug that you hear on TV. Problem is all those drugs will worsen orthostatic hypotension. So, and usually they work at the beginning, then as the disease progresses, they don't work anymore, and then you have to make decisions regarding the patient's situation, their age, etc., if more invasive options are indicated or not. For the sweating abnormalities, which again heat does not have, there isn't anything we can do really to reverse lack of sweating. So the patient will need to learn tricks to basically externally cool themselves, besides being in a cool environment, spray themselves with cold water, etc. For the motor aspect, again, unfortunately for the attacks, there isn't much we can do. But obviously we encourage them to have speech therapy. There are definitely techniques to improve intelligibility. When and if they develop dysphagia, again, at the beginning, there are strategies that could be tried, and then some of them will evolve into the requirement of a feeding tube. For the sleep disturbances, I mentioned already, the biggest thing is making sure that they don't die because they quit breathing at night or because of a stridor. For REM behavior disorder, there are medications, generally melatonin and clonopin are the drug of choice, usually work fairly well. For the C-type, it's less common than the P-type, at least as an onset. Let me say a word about the P-type. How do you differentiate from Parkinson's disease? Usually at the beginning, the thing that may give it away is the fact that they don't have tremor generally. And the classic posture of the Parkinsonian patient is sometimes not there. They generally have a more normal posture. And again, then you have to shake the tree and question about the presence of any of the other abnormalities that we talked about. Again, at the very first visit, sometimes it's really difficult to really make a diagnosis. So if you are suspicious, just see the patient back. And sometimes you may not be suspicious. Sometimes it's literally impossible. But again, the patient usually declares himself not safe at all. But you need to think about it, and you need still to make sure you're not missing something potentially treatable. So the autonomic ganglionopathies. Look for amyloid. That's another thing that usually it's a big thing to sort out. And some are treatable, some are not. But anyway, I think our time is up.
Yes, thank
Questions?
you.
Yeah, do we know what the etiology of MSA is? What is the etiologic factor there?
What actually triggers it, we know it's a neurodegenerative disorder, and it's a deposition of synuclein into the cells and causing all this process. So it's a protein that it's present normally, but it's equivalent to sort of, at the level of, for, the tauopathies, Alzheimer and the like. It's the same concept. This other system is a synuclein that accumulates, and depending where we know that the accumulation starts many, many years before the clinical manifestations. And depending where the accumulation happens more rapidly, that will be the presenting scene.
There's no genetic or familial.
There is the Asian one. In Japan, there's been this Dr. Shuji, whatever it's pronounced, did this study showing there is this gene which actually is related to coenzyme Q, but it's only in Japanese. We have not found one single case in non-Asians, non-Japanese. Indeed, for us, it's almost a diagnosis of exclusion. If the patient tells us that they have a family history, then we think of something else.
Thank you.
Thank you all for coming.
Thank you.